الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. This lecture, Gonorrhea, due to Neisseria gonorrhoeae by Professor Mahmoud Hani Sulaiman. Definition: Gonorrhea is a sexually transmitted infection caused by the organism Neisseria gonorrhoeae. Microbiology: it is a gram-negative intracellular Diplococcus fastidious microorganism, grows only in vitro in narrow temperature range from 35 degrees centigrade to 38 degrees centigrade on complex media. It has a marked ability to develop resistance to antibiotics. Recently, there was global strains with increased resistance to third-generation cephalosporins. Gonococcus is naturally content. This is a factor that led to rapid acquisition of antimicrobial resistance. Microbiology continued. Neisseria gonorrhoeae is an exclusively human pathogen. It uses different pathogenic mechanisms to infect epithelium of men and women. In men, H-glycoprotein receptor present on urethral epithelia interacts with terminal galactose of liposaccharide (LOS) to enter human cells. In women, a cooperative interaction occurs among C3b covalently linked to LOS, gonococcal prion and pilus and complement receptor 3 CR3 on surface of cervical epithelial cells. Clinically, gonococcal infections in children and adolescents occur in 3 distinct age groups. First, infection in the newborn infant usually involves the eyes. Other possible manifestations of neonatal gonococcal infection include scalp abscess and disseminated disease with bacteremia, arthritis, or meningitis. Vaginitis, urethritis may occur as well. In children beyond newborn period, including pubertal children, gonococcal infection may occur in genital tract and almost always is transmitted sexually. Vaginitis is most common manifestations in prepubertal females. Progression to pelvic inflammatory disease, PID, is less common in this age than in older adolescents. Gonococcal urethritis is possible but uncommon in prepubertal males. Anorectal and tonsillopharyngeal infection can occur in prepubertal children and often is asymptomatic. These are cases on the left side. An infant with gonococcal ophthalmia in hospital. Evaluation and treatment is recommended for infants with gonococcal ophthalmia. Gonococcal ophthalmia neonatorum due to maternal gonococcal infection. Unless preventive measures taken, it is estimated gonococcal ophthalmia neonatorum will develop in about 30% of neonates of women with gonorrhea. It affects cornea epithelium, leading to keratitis, ulceration, and perforation. The third one on your right side, profuse purulent vaginal discharge in an 18-month-old girl who has gonococcal vulvovaginitis. In a pre-adolescent children, this infection is almost always associated with sexual abuse. Identification of species of cultured gonococci is imperative in suspected cases of sexual abuse. In sexually active adolescent and young adult females, gonococcal infection of genital tract often is asymptomatic. Common clinical syndromes include urethritis, endocervicitis, and salpingitis. In males, infection often is symptomatic, and the primary site is urethra. Infection of rectum and pharynx can occur alone or with genitourinary tract infection in either gender. Rectal and pharyngeal infections often are asymptomatic. Extension from primary genital mucosal sites in males can lead to epididymitis, and in females can lead to bartholinitis. Gazes again on your left, this patient presented with gonococcal urethritis, gonococcal conjunctivitis of right eye. If no treatment, Neisseria gonorrhea may spread to bloodstream and throughout the body. This is a case of disseminated gonococcal infection showing this lesion. Another case, this colposcopic view of this patient's cervix revealed an eroded ostium due to Neisseria gonorrhea infection. Eroded ostium. A chronic gonorrhea infection can lead to complications that can be apparent at this cervical inflammation, and some can be quiet, giving the impression that the infection has subsided while treatment is still needed. In sexually active adolescent and young adult females, PID with resultant tubal scarring and perihepatitis with Hughes-Curtis syndrome, even asymptomatic infection in females can lead to PID with tubal scarring that can lead to ectopic pregnancy, infertility, or chronic pelvic pain. Infection in other mucous membranes can lead to conjunctivitis, pharyngitis, or proctitis. Hematogenous spread from mucosal sites can involve skin joints, leading to arthritis, dermatitis syndrome, disseminated gonococcal infection, and occurs in up to 3% of untreated people with mucosal gonorrhea. Bacteremia can lead to maculopapular rash with necrosis, tenosynovitis, and migratory arthritis. Arthritis may be reactive, sterile, or septic in nature. Meningitis and endocarditis occur but rarely. This picture shows gram-stained smear of urethral exudates showing intracellular gram-negative, here this organism, gram-negative diplococci that are characteristic of gonorrhea. This picture also shows intracellular gram-negative diplococci isolated on culture of petechial skin lesion. This also shows Neisseria gonorrhea with numerous villi extending from the cell surface. Epidemiology of gonorrhea. Gonorrhea occurs most commonly in adolescents and young adults worldwide. Overall incidence is declining, however, an exception is among men who have sex with men. No gonorrhea should be considered in evaluation of genital inflammatory syndrome, including cervicitis, urethritis, and pelvic inflammatory disease. Most infections are asymptomatic, thus routine screening of young women less than 25 years or older women with key risk factors is recommended. Untreated maternal infection may lead to ophthalmia neonatorum, which may be prevented with neonatal prophylaxis. Although transmission from males to females is easier, in females infection is often mild, and many women who are infected have no symptoms of disease. Most patients who report are males only. If symptoms of gonorrhea develop, they usually appear in 2 to 10 days. This is the incubation period after sexual contact with an infected partner. Although a small percent of patients may be infected for several months without showing symptoms. Men are more likely to show symptoms than women. Symptoms in men include burning sensation during urination and yellowish white discharge from penis that usually stains undergarments. Symptoms in women include painful burning sensation when urination, yellowish or bloody discharge from vagina, bleeding between periods, and abdominal pain. Complications of gonorrhea in males include posterior urethritis, urethral stricture, cystitis, prostatitis, seminal vasculitis, epididymoorchitis, and urethral fistula. In females, pelvic inflammatory disease, salpingitis with resultant infertility or ectopic pregnancy are important complications. This figure, the first on the left, gonococcemia with maculopapular and petechial skin lesions, most commonly seen on hands and feet. Adolescent with septic arthritis of left ankle with petechial and necrotic lesions on feet. Blood cultures were positive for Neisseria gonorrhea. Intracellular gram-negative diplococci isolated on culture of epithelial skin lesion. These two figures shows the one on the left, patient with cutaneous gonococcal lesion with disseminated Neisseria gonorrhea. Although gonorrhea is sexual, if no treatment, it can disseminate through the body to extragenital lesions. Extragenital. Male with purulent penile discharge due to gonorrhea with overlying penile pyoderma. This is the pyoderma. Lesion. Pyoderma involves formation of purulent skin lesion, as in this case on glans penis, and overlying sexually transmitted infection of gonorrhea. This picture shows patient presented with symptoms later diagnosed as due to gonococcal pharyngitis. Gonococcal pharyngitis is sexually transmitted infection acquired through oral sex with an infected partner. Most throat infections caused by gonococci have no symptoms, but some with the infection can experience mild to severe sore throat. Diagnosis of gonorrhea. Diagnosis is made through detection of bacteria in samples taken from the urethra, cervix, throat, or rectum. It is generally more cost-effective to treat presumptive chlamydial infection also in all persons with gonorrhea. Do culture and nucleic acid amplification testing are sensitive, specific, and can be performed at all potentially infected anatomic sites. This picture shows gram stain of cervical discharge in an adolescent who has gonococcal cervicitis. Note multiple intracellular diplococci. In children with suspected abuse, it is imperative that gonococcus be cultured and identified to distinguish pathogens from normal flora. Prevention of gonorrhea. Because of the asymptomatic nature of most infections, routine screening of young women less than 25 years and pregnant women is recommended. Condoms are very effective in preventing transmission. Other prevention strategies, not so important. They are trying to use outer membrane vesicle meningococcal B vaccine to prevent gonorrhea. Therapy. Because of widespread resistance to numerous antibiotic classes, options are limited. The options are parenteral therapy with third-generation cephalosporins, better given with azithromycin. Sex partners should be treated. Patients in whom treatment with standard regimen fails should undergo assessment for reinfection. If reinfection is unlikely, antibiotic resistance should be considered. This is the options for the treatment. Uncomplicated infection of the cervix, urethra, and rectum, give single dose of ceftriaxone, better with azithromycin single dose. Infection of the pharynx, ceftriaxone and azithromycin single dose. It is like a magic, one single dose. Conjunctivitis, not ophthalmia neonatorum, ceftriaxone, one single dose intramuscularly. Disseminated gonococcal infection, this is different. Ceftriaxone 1 gram intramuscularly or IV every 24 hours for 2 days. Meningitis and endocarditis, ceftriaxone 2 gram intravenously every 12 hours for 2 weeks. Ophthalmia neonatorum, ceftriaxone 25 to 50 milligram per kilogram intra-V or IM in a single dose not exceeding 125 ملغ. وفي النهاية لا أجد أن أقول الحمد لله رب العالمين و thank you for your good listening.